Hello, everyone. Good afternoon. I'm Andrea Hodgman, Associate Director for Intellectual Engagement and Travel with UChicago Alumni. Welcome to UChicago Weekend at Home. Every year, Alumni Weekend is an opportunity for the University of Chicago alumni community to come together to celebrate your connections to each other and to campus, and to the spirit of continued learning and inquiry. And this year, we're excited to bring that same energy to you wherever you are in the world. Now, please allow me to introduce our presenters for this afternoon, Dr. Neda Laiteerapong and Dr. Daniel Yohanna. Dr. Laiteerapong is Associate Professor of Medicine, Associate Director of Clinical Outcomes for the Center of Chronic Disease Research and Policy, and Director of Primary Care Behavioral Health Integration in the section of General Internal Medicine in the Department of Medicine, with a secondary appointment in the Department of Psychiatry and Behavioral Neurosciences at the University of Chicago. She is an NIMHD AHRQ-funded health services and outcomes researcher, a board-certified internist, and a clinical informatician who studies translational questions at the intersection of diabetes, mental health, and individualized care. Much of her research and informatics work has focused on implementing system-level interventions in and outside of the electronic health record for how increasing the provision of and access to mental health in primary care and other settings. She also dedicates a portion of her effort towards improving health disparities and advocating for a better quality of life for clinicians. She is also an alumna of the BSD Department of Public Health Sciences, Masters of Science for Clinical Professionals. Dr. Yohanna received his medical degree from Rush Medical College in Chicago and completed his internship in psychiatric residency at Northwestern University Medical School. Dr. Yohanna joined the Northwestern University Medical School faculty in 1986 and later joined the University of Chicago Pritzker School of Medicine faculty in 2005 and is now the interim chair and associate professor in the Department of Psychiatry and Behavioral Neuroscience. He was board certified in psychiatry in 1988 and in forensic psychiatry in 1999 and recertified in 2009 and 2019. Dr. Yohanna has served on or chaired many committees and task forces on the treatment of the severe and persistent mentally ill. He was elected to the Council of the Illinois Psychiatric Society in 2003 and served as president for the 2006 to 2007 term. He has published and lectured on integrating behavioral health in primary care, chronic mental illness, and forensic psychiatry. He is the current co-PI for the ECHO Chicago series on serious mental illness, a training program for primary care clinicians in free and FQHC facilities. Please submit your questions in the comment box. There will be Q&A section at the end of the presentation. And without further ado, I will turn things over to you, Dr. Yohanna.
Thank you very much, Andrea. And it's my pleasure to talk with the alumni today. And hopefully we'll have a lively discussion at the end. So I wanted to talk about a timely topic of mental health during this COVID-19 pandemic. As you all know, it's been a extraordinarily trying time for many. And I'll talk to you a little bit about what we've learned and what we've done at the University of Chicago. Next slide, please. So the problem, just to look at from the beginning of the year on January 1st, there were 83 million plus people who were infected with COVID and 1,800,000 over 1,800,000 who had died. In the US at that time, there were almost 20 million people infected. That was the most in the world, and 345,000 deaths. Next slide, please. Just as of this week, the numbers now have grown significantly to 170 million people affected in the world, 3.5 million have died, and in the US, 33 million have been infected, again, the most in the world, and very close to 600,000 people have died, again, the most in the world. Other parts of the problem is there's been new strains of the virus that have been detected in 33 countries around the world. But I want to point out that it has not affected everyone uniformly in the United States. and it's been particularly problematic for our community near the university. Next slide, please. And the reason for this is multifactorial. Not only are in our community, there are households that have multi-generational people in it, so there's more likelihood for exposure. And many of our community are essential workers who are on the front lines. Urban communities have higher rates of infection, and underlying health conditions, which also affect our community of more than other communities. And there are clearly, as you all, I'm sure, have been aware of, structural inequalities in our system. It's in our healthcare system, in our housing and employment systems, that is really now hopefully will be addressed. Next slide, please. So what have we seen in the general population? So in the beginning of this pandemic, in a survey of in communities around the country, 40% of respondents in June reported depression or anxiety, 31% depression or anxiety, traumatic stress and 26%, increased substance use disorders and 13%, and suicidal ideation in 11%. It has been just an overwhelming mental health problem in a system that has been underfunded for many years. And because of those structural inequalities and other issues I mentioned, it's higher in our African American communities, Hispanic, essential workers, adult caregivers, and those with pre-existing conditions. Also, we know that people who initially, many were in the ICU. Thankfully, the numbers are very low now. I think today there are perhaps 35 COVID patients in our hospital, when during the peak, there were over 220. And many of the survivors are left traumatized from any ICU experience. And 1 in 5 COVID-19 patients were diagnosed with a mental illness within 3 months of getting sick, 29% with depression. And depression following all critical illness is associated with increased mortality in the first 2 years following discharge from intensive care units. Next slide. If that weren't troubling enough, problematic enough, mental health for our healthcare workers was a concern from the very beginning of this. We knew from SARS outbreaks in the past that healthcare workers had very high rates of mental health issues, of increased rates of substance use, smoking, drinking, increased absenteeism to work, and increase what's called presenteeism, which means they're present, but they're not working at their full capacity. We also know from the SARS outbreak at the time that 20% of the ICU workers had PTSD symptoms after 2 months of exposure. Burnout in mental health, and we'll talk about what that is in a minute, has increased. But even before COVID, roughly 50% of physicians reported symptoms of burnout. And then during COVID, 78% of psychiatrists in North America had high burnout scores and high scores on what's called a scale for depression, PHQ-9. 16% had moderate or worse depression. And in all healthcare workers during COVID, 23% had anxiety, 22% depression, and nearly 40% had some sleep disturbance. Next slide, please. So when we start thinking about what to do, I mean, you have to define the terms. A disaster is an event that requires resources beyond the capability of a community and requires a multiple institutional response. So one of the problems with COVID is that when you see a disaster in one place, fire or tornadoes, hurricanes, and so on, we have the rest of the country to come to our aid, firefighters from other states, et cetera. Well, this affected everybody across the country. There was nobody coming to our rescue. We had to use our own resources. And a trauma is an event that requires coping resources beyond the capability of the individual. Stress is a state where your body devotes coping resources in response to the environmental challenge or trauma. And burnout is a depressive-like state. Usually this is in reference to workplace, although originally this was described for healthcare workers. And there are scales that we use to inventory our staff. And the traumatic stress plus the burnout is something we call compassion fatigue. Next slide, please. And this is what we were really most concerned about. This is a traumatic, secondary traumatic stress related to the decreased ability to be compassionate to another person. It affects all different areas of thinking, emotion, and behavior. And in these scales, the sort of questions where you no longer really feel patients are burdensome to you is the kinds of things that affect your ability to care for others, and your work performance decreases. Next slide, please. So what happens in a trauma? Very briefly, there's a period initially after a trauma where people come to your aid. There's a sort of a honeymoon period, but then there's a long period of disillusionment. And it takes, this can last up to a year, and then it takes a long time to come back to your previous level of functioning. The next slide, please. And so in a pre-disaster, we needed to do much more to prepare for a pandemic. There were preparations, of course, made. How they were implemented is up for debate. And then during the acute phase, we have to ensure that people are safe, try to diminish people's suffering, preserve function, and promote resilience. We'll talk about resilience in a minute. And in this post-acute phase where we are now, regain some sense of mastery and control. For those who have gone out and been vaccinated and gone to a restaurant in the last month or 2 weeks, you'll know really what a pleasure that is. And to resume your activities. The next slide. So just very briefly, and as we have already said, there's all these distress reactions. One has the psychiatric symptoms, the health risk behaviors, and what we worked on was to improve the resilience in our healthcare workers. Next slide, please. So just what is resilience? So it's the capacity to withstand stress and catastrophes, to work through the emotions and the effects of stress and painful events. And it's a product of many things: one's own development and upbringing and support growing up, how you think about disasters, and how you're physiologically, how you emotions are affected. Next slide. So how do you create this? So I'm not going to go through all this in great detail. I'm going to tell you what we did within our institution in a moment. But many things that are of common sense to stay informed, but not overly informed. We encourage people not to watch every bit of news. Do the things that are good for yourself. Use others in your life to help you. Stay spiritually grounded. There's many techniques to improve your relaxation techniques in your body, to relax your body, mindfulness, and techniques, which we'll just talk briefly about in a moment, and just to be kind to yourself. People in disasters tend to overwork, and with some pride about how much they work, and we had to dissuade people from doing that. Next slide, please. So here's what we did. So we started to train people throughout the institution in a series of what we called antibodies that were delivered through their unit supervisors or peers during rounds or huddles. So we taught people brief interventions for not only to relax your body, but also to thank others, to find heroes within your work. And we trained as many leaders and residents as possible to do a brief mindfulness exercise prior to rounds. Now, for those who reach out, we had a peer support line staffed by our peers. This wasn't a therapy line, but allowed people to call and talk to others. And there was peer support, and we helped people and nudge them toward the more formal help through the employee assistance program. That was not really an intervention. And for everyone else, we had daily wellness Zoom trainings at noon with mindfulness, yoga. They were 30 minutes apiece. Anybody could enter, just like you have for today's talk. And we've had everything from not only yoga, mindfulness, music, and many people, and we're still doing it, by the way. Many people were involved in that. Next slide, please. So what happened? So we were evaluating people for those who had no antibody groups and those that did have the antibodies. And as you can see, the trend for those who didn't have any interventions, that they had higher scores of burnout, and that for those that did, the trend was a reduction. Now, this didn't stop burnout or compassion fatigue, but we do think that it assisted in reducing the numbers. In addition to all this, of course, we had our department available for more individual psychotherapy, medication management, and groups. Next slide. So I think that concludes this portion, and I look forward to any questions you may have.
Hi, everyone. I was on mute, obviously. Neda Laiteerapong. I'm really excited to be talking with you all today. I'm hoping my slides will get pulled up for me. Here we go. Oh, looks like we're away from our slides. Dr. Yohanna and I have been collaborating for the last over 5 years on our behavioral health integration work, which I'm going to talk a little bit about what primary care behavioral health integration is and how it's a different model of taking care of mental health than you might be familiar with. And then I'll be talking in some detail about the program that we have at the University of Chicago in our primary care department. So, you can go to the next slide. So, I probably don't have to tell you all, but if you've ever tried to get a mental health provider for yourself, a loved one, or a friend, there just aren't enough of them. So this is a map of the United States, and it's the concentration of primary care providers. And you can see here the light colors. So you can see that there's differences across the country in terms of the number of primary care providers, the density of primary care providers, where some places have a lot and some places just don't have as many. If you go to the next slide, the problem is even incredibly pronounced in child and adolescent psychiatry. This is a map of the US, and you have green being mostly sufficient supply and then red being severe shortage. And there is a severe shortage of psychiatrists in the US, except for maybe the Northeast and Hawaii. So that is the problem. The next slide also goes into a little bit more detail. This one is a map of what's called health professional shortage areas. So the United States is tracked in terms by the federal government in terms of the ratio of primary care providers to the population, as well as mental health providers. And so this is the map by county for 2021, where they're describing to what degree the county is in a shortage area, meaning the ratio of mental health providers is considered insufficient for the population. And light blue is none of the county is in a shortage area, meaning there is good access throughout the entire county to a mental health provider. And dark blue means every single county in the area is really struggles to find a mental health provider. And this includes social workers, counselors, psychologists, as well as psychiatrists. You can see most of the country is dark blue, severe shortage. And there's a projected shortage of 250,000 mental health providers by, just 4 years from now. So, you just can't find, it's very hard to find a mental health provider, especially when you need one. All right. Moving on, we're going to talk about a potential solution. So one potential solution is actually integrating primary care and behavioral health care so that way people can get behavioral health services in the primary care setting. So in the US, 75% of adult Americans have an identified primary care physician, and it's higher for kids. But in 2020, during COVID, there was a huge drop in primary care visits, but actually that rates are climbing back up again quite quickly. And there's an interesting paper by a former University of Chicago grad faculty member who's now at a different institution, Caleb Alexander, and he published this paper that sort of actually paralleled the use of telemedicine, which was a major strategy in primary care and other specialties to ensure primary care or ensure people were getting mental health care. And you can kind of see the overlap between the COVID death rate and telemedicine adoption. All right, moving to the next slide. So 75% of actual people, in addition to 75% of adults having a primary care provider, 75% of the mental health providers are actually primary care physicians. So when people with mental health problems are asked who provides your mental health care, 75% of them actually report it's their primary care provider. So primary care providers are actually the de facto mental health providers in the US and internationally. And many major organizations, for example, here the World Health Organization, but many organizations have sort of said, well, you know what, treat people where they are. If people are going to a primary care provider, then let's try to get our primary care providers to do mental health care and integrate care that way. So there's three major levels of integration between behavioral health and primary care services. The first one is sort of where lots of places have historically been, and many places still are, which is coordinated. It's sort of how, you know, primary care interacts with many specialties. For example, if you have a problem with hip pain and you might need a hip surgery, we'll refer you to an orthopedic surgeon, and then we'll talk about that. The doctors or the providers will talk with each other about that case, but then after that case is over, no need for the primary care doctor and the orthopedic surgeon to have a conversation anymore. And that's coordinated care. And that's not really a form of integrated behavioral health care, but it's sort of where a lot of places start. The second level, which really gets you started in integrated behavioral health, is co-located care. So this is shared physical space and communication about shared patients. So this is placing a social worker, a therapist, a psychologist, or a psychiatrist physically in the primary care clinic, and still doing referrals, but because of the co-location, you start to have conversations. Well, I saw this patient this week. Can I ask you about them? What do you think about this case? The cultures start to blend a little bit, but still really communication is mostly fixed on shared patients. The next level of care is integrated care. And this is care where patients are cared for by the team. Primary care providers and the mental health providers are on equal footing in terms of their responsibility for the person's care. It's not like the primary care doctor takes care of their hypertension and diabetes, which is for some reason separate than the person's depression. No, it's whole care. The mental health providers and the primary care providers are managing the patient who happens to have hypertension, diabetes, and depression. And then the treatment plans are actually collaborative, where people are thinking about both problems. So compared to like coordinated care, where someone might start a medicine for someone, but that makes some other different specialist says, oh, that's a terrible medicine for your eyes. That one's going to cause problems for your eyes. It might work for that part of your body, but it's not working for that part of your body. So integrated care really tries to think about the person in whole and coordinate care across the different members of the team. So then the model can get actually pretty complicated in terms of what are the things that are being coordinated. And this is a great model of integrated behavioral health care, which tries to put everything on one page with integrated primary behavioral health care like right at the center. And there's key components that are important. So I talked a little bit about joint decision making and co-location. There's also the communication and collaboration part, but then there's technical parts like, do they have the same medical record? Do they see the same list of medications? Can they see the same treatment plan? Are they sharing in terms of expertise? Are they training each other? Are the mental health providers training the primary care doctors on how to do something more advanced than just talking to patients, something like motivational interviewing or a little bit of problem-solving therapy, those types of skills? And is the primary care doctors training the mental health providers just a little bit on hypertension, a little bit on diabetes to make that management a little bit easier for everyone? So there's two major models of integrated behavioral health care that are worth knowing about. The first model I'm mentioning is the collaborative care model. There have been over 30 trials that have tested this model of care, and it actually now has billing codes where this model of care, health systems can get reimbursed for providing this care. Has shown good evidence to improve mental health for depression, anxiety, substance use, and some studies for PTSD, post-traumatic stress disorder, and other mental health conditions. And if other specialists are included that focus on diabetes or hypertension, for example, it also can improve diabetes and hypertension. In addition, it's actually been shown to be cost effective. So this model includes new people to the team. So there's a behavioral health care manager, which manages patients who have depression or anxiety or whatever the case may be, using technology, just a registry of patients and sort of very clear measurement-based care, measuring symptoms, using the PHQ, which Dr. Yohanna mentioned. So measuring symptoms, asking, thinking about the patient's case, talking to the patient, and then consulting with a psychiatrist about the case. Okay, so the patient's on this medicine, do you think we should change it? Communicating that information all back to the primary care provider, and then also doing some brief motivational interviewing as part of the process. So this is one very common, well, not very common, increasingly common strategy for integrating behavioral health care. Hold on just a second. And the second model is the primary care behavioral health model. This model includes a behavioral health professional, usually a psychologist or a therapist, or actually one of those two, social worker, who've been trained, especially trained in behavioral health, or nurse practitioner. And primary care providers refer patients to the behavioral health professional who have some behavioral health complaint, not just depression or anxiety, but any number of problems. And the behavioral professional engages that person in brief interventions, usually lasting about 8 to 12 weeks, or about 8 weeks usually. 30-minute sessions, which is different than classic long-term therapy, which are usually hour-long sessions, and they can go on indefinitely. So brief interventions, 8 weeks, 30-minute sessions, and really focus on solving problems for that patient. And then that allows the behavioral health professional to manage many patients and support patients in the primary care setting. So they're available for warm handoffs. Oh, I've got this person right now. Can you come talk to them? I'm worried about them. And then the behavioral professional can come in the room, and then they also see patients on their own who are all patients of that clinic. So those are the two most common models of care that are worth knowing about integrated behavioral health care. And then I can talk a little bit about what we're doing here at the University of Chicago. So as I mentioned, we started working, you can go to the next slide. We started working on this in December, like a long time ago, December 2014. We started meeting monthly, start brainstorming and solving issues related to primary care behavioral health integration. All of us listed here had individual patient cases that were, we were not happy with the outcome, and we thought that we could do better for our patients. So myself, Dr. Yohanna, Dr. Vinci, Dr. Rougeau, who joined the team a little bit later, and then Aaron Staub, who is the research specialist in mental health and helps manage the program. So our vision is seamless physical and behavioral health care for the University of Chicago community. And when we set out this vision, we understood that it was broader than the clinic that I work in Hyde Park. It was really about the community and how we could change things for the whole community. So while we pilot test and do a lot of things in my clinic, they also could have influenced how the other clinics at the University of Chicago sort of manage care and affects the providers as well. So I can talk a little bit more about the individual interventions that we've done. So we have our behavioral medicine clinic. This is a co-located, integrated clinic that is run by health psychologists. So we're using that second model, the primary care behavioral health model. But in addition to having that model, we've actually stood up a lot of resources and education. So we support primary care providers in their identification and management of behavioral health needs. We send out weekly email tips on Fridays to empower our providers to manage behavioral health problems more effectively. So teaching our providers things that, providing that cross-training that is usually lacking. So training our primary care providers on what is motivational interviewing, what is problem-solving therapy, what is DBT, dialectical behavioral therapy. These are not things that are taught to physicians. We just don't learn these things. But knowing just a little bit about that can be very helpful. We also develop electronic health record innovations for University of Chicago Medicine, fixing problems in the system to allow us to use the EHR and not to have the EHR use us, is how I put it. We also problem solve around individual cases, as well as advocating for increased access to behavioral health care within the University of Chicago, as well as the community. So we partnered with about 12 community therapy partners, where we actually have closed loop referrals with those partners, where we send information about referrals to them, and they tell us actually if the person got scheduled or if the person declined the referral. And that has been invaluable for our providers, because it's really hard to get people, ask providers to screen for a mental health condition and then be like, well, that's great that you found it, but I don't know where to send them to. No, now we have this community of mental health providers that are have actually been open during COVID to take our referrals, and that has been that's been a huge help to our providers and our patients. So we also lead the depression screening and management system at University of Chicago through to make sure we do that, and then the whole time we're evaluating and doing research. Go to the next slide. So the Behavioral Medicine Clinic, this is just a brief slide about it. You know, they also have a lot of groups, group classes that they provide. This is their mindfulness group. It's available for scheduled appointments, curbside consults, and warm handoffs. And then these are a little bit more information about our weekly tips. To date, this slide is a little bit outdated. It's been more than 150 weekly tips because we started this in, I think, 2016, and we've sent out a weekly tip every Friday since then. So it's been a lot. We feature the efforts we're doing in our clinic, and then information, and then community resources. And this was very helpful during COVID. You know, as Dr. Yohanna mentioned, our providers were under distress. And so we would have weekly tips that were geared towards our providers, but geared towards our patients too. I heard literally just this weekend, someone who got my tip, the tip said, you know, that one on cognitive load was a really, really good tip for me. You know, thinking about, you know, how hard it's been during COVID, and then it's been the cognitive load, all this new information, and help them sort of think through what they were doing on a daily basis and how to sort of decrease the cognitive load and say it's okay to shut it off sometimes. All right, next slide. And then we do have a lot of clinical decision support tools that we've developed. There are about 12 of these now for the very common mental health conditions that primary care providers see, and they're all algorithmic, one-page pretty colors to try to make it easy. So they talk about what a good screening tool would be, how do you interpret that screening tool, what medications to start, patient education tools that we have, etc. And then we've gone through and tried to find brief screeners for all the common mental health problems. So that way a primary care provider could say, oh, I think this person might have PTSD, but I don't know how to screen for that. You know, I'm just going to refer to psychiatry. Well, you know what? Psychiatrists are really hard to come by, even at the University of Chicago. So why don't we have you start the process? So here's the screener, and then there's a clinical decision support tool for how to interpret the information. And gosh, you can even start that first medication for that patient. So here's just a really brief report of one of the interventions that we did, which was changing how our system did depression screening. So usually what would happen for depression, you might come to the doctor, and the person, you know, depending on how you looked or what you said, might decide to ask you about your mood. And that obviously, you know, clinical studies have shown that you miss about half of people with depression if you do it that way. So we launched electronic health record tools to sort of nudge doctors to do to ask about depression. Well, that didn't really work. That was what you can see was we started at 11%. People were just doing depression screening on their own on chart review. And then we turned on the best practice advisory and watched it for about 5 months, and nothing happened. So they said, okay, well, let's try some physician report cards. Let's ask our physicians, let's show our physicians how they're doing compared to their peers in terms of how often they're screening for depression. Let's see if that works. And it worked a little bit. We got to like 20%. So we doubled the number, but still not great. And then we said, okay, well, let's change the health system. Let's get permission for our medical assistants to start asking about depression. And that started in September 2017. And you can see it instantly went up to 55%. And then I can tell you at this point, we're screening 70% of people, at 70% of appointments, so the patient is getting, if they're due for it, they're getting screened, which we're really happy about. I mean, when people come to the doctor, they're not necessarily asking to be screened for depression, but 70% of the time they do get asked that question. And we've been able to identify a lot of people with depression who we didn't know about beforehand. So a little bit about our electronic health record innovations. I talked about depression screening. We also have a system for monitoring and surveilling people who have a history of depression. We've pushed new orders out for referrals to our psychiatry and psychology psychiatry and psychologists to make it easier for that triage process. We also have a lot of electronic health record patient education tools that sort of provide the first intro health psychology about kind of like what the patient might get if they went to that first therapy appointment. And then we have a depression registry that pulls all the patients and puts all the patients in one place so that we can start to actively manage that population. Go to the next slide. And then I did mention our closed loop referral system already. So we have about 12 partners, and each therapy group is different and unique in terms of what insurances they accept and what types of patients that they provide services for. They provide services for minority populations or people who speak other languages. So we have all the information captured, and we push it out in our weekly tip emails, and we actually have a website too that has that information. So you can just go through these slides, and the whole time we're producing science, new science about how to actually integrate and improve behavioral health integration. So this is an example of a couple papers that describe our quality improvement over behavioral health integration. So that's those are the questions, or that's my talk, and I'm happy to take any questions. And that last slide there actually had the website link for our program.
Thank you, Dr. Yohanna, and thank you, Dr. Laiteerapong. I really appreciate your work. As someone who has been on a waiting list for a therapist, I really appreciate the work that you're doing. We have lots of audience questions, and I'd love to get into some of them with you. First, I'm just curious how might we encourage people to go into the field of mental health, into psychology, psychiatry? What are some solutions you might see for that?
Well, thank you, Andrea. I was going to answer that question, I think, anyway, for all the audience. What can we do? So I think there's a few things. Behavioral health has been under-reimbursed for a long time. For example, even in Medicaid in Illinois, psychiatry was paid about a third of what, say, OB-GYN was paid. So you're not going to get, build it and they will come, pay for it and they will come. So I think one thing is to improve the reimbursements. The second, we worked many states, including in Illinois. We reimbursed school loan reimbursements if you went into primary care. We need to do the same for all behavioral health, to make to entice more people to go into it. And already as mentioned, the collaborative care model, the more that we can train people to work with primary care, as Dr. Laiteerapong has said, the outcomes are good, and we can get to more people that way. And lastly, we need to not lower our standards, but have different levels of behavioral health in the community. And they do this around the world, where people in a community are identified with information and some interventions for behavioral health. Now, we're not going to get down to barefoot doctors like in some countries, but that model is a wonderful model to train more community people. We do this, for example, in violence prevention. We train people within a community to be interrupters. Same idea in behavioral health. We need to train more people all the way down the line, and they should get something for it.
Great, thank you. Catherine Gao has a question about the wellness workshops. Do you see these wellness workshops and antibody trainings as something to incorporate more permanently in the hospital's infrastructure to support healthcare workers?
So we've gotten just very wonderful support from the institution, from the dean all the way, the president of the hospital all the way through. So those kinds of supports is what programs to continue. We knew already that burnout and compassion fatigue was a problem, so we will continue to do workshops or have some kind of daily wellness program, I think, for quite a long time, even now that the pandemic is nearing some end. Thanks for that question, Catherine.
Thank you. And in that sort of vein, do you anticipate that telehealth for mental health will remain on a prevalent option for patients? As someone who couldn't find childcare or is homebound, do you think that those will continue?
So if there is a silver lining to this mess, telehealth will be one, could be one anyway. So it's been very successful for mental health, more so than physical health, even though I think it's worked well for follow-ups and so on. It's worked very well for us for a number of reasons that you just mentioned about people getting access. So we saw a 20% increase in visits this year. And most of it was because half of it was because we had practically no shows. We found people, we called them, telephone. So it's worked very well. And I think there's an appetite across the country to continue telehealth. If not telehealth, then telemental health. I think has even a better chance. So there's a bill, for example, in Illinois, House Bill 3498, if you're counting, to support. And there's a federal bill that we've been working with our senators to support telemental health. Now, the big problem is cross state lines. During the executive orders, in most states, they've allowed physicians and mental health clinicians from other states to see people. That may end. We'll see what happens. But within state, and if you're licensed in that state, I think we have a very good chance. Of course, the pushback is from insurance, who doesn't want to pay the same for telehealth that they do for in-person care.
Thank you so much. So much of what you're talking about and the work that you're doing, it reminds me of my background, which is teaching, and how much one single teacher has on their plates at a time. And so I have a question for Dr. Laiteerapong. How have primary care physicians reacted to the more collaborative work and asking them to take some of this on?
That's a great question. Thank you. Yeah, you could imagine that some people would be like, oh, that's more work for me. I would just refer out. And it comes down to the fact that primary care providers are driven to take care of their patients, So while it can feel like, oh, I'll just refer out, and then I go, well, where? Where is that psychiatrist you're imagining is out there? And they go, that's a good point. And I'm like, do you want to spend the next 4 months having that person go back and forth with their insurance company, calling, getting rejected, or do you want to just start that first medicine? I would say that I'm blessed. Here at the University of Chicago, it's sort of this unique place where our primary care doctors are just very motivated and willing to learn new things. They're super busy, don't get me wrong, but they are willing to they have taken on the learning of these new problems that before they would try to just be like, well, I don't know, I can't find a psychiatrist, but I'm just going to not ask them about their mental health. And then we'll just talk about their hypertension and diabetes. And, I can't seem to get that under control, but it's okay. I'll just keep on focusing on that. So, and there have been people that, I've had to have sit down conversations with and be like, how's it going? It's been a challenge, culture change. But people have been really receptive. And I think that, we are, and as a result, we are actually still asking for more help. So we are standing up our own, hopefully, knock on wood, collaborative care program in conjunction with our primary care behavioral health program, because my primary care providers say, now we've found all the people and we still need more help. So, which I think is a good thing. I think, I think that ignoring the mental health as we've been doing traditionally doesn't serve anyone well.
Thank you. That also sounds a lot like other teachers who are willing to do whatever it takes for their students. So that makes sense. Thank you. This question is for both of you from Andrew. Do you anticipate any potential shifts in mental health behavior following a return to normalcy in the United States? I know, Dr. Yohanna, you mentioned how nice it is to go out into a restaurant. So could you talk a little bit about that?
I think, as I said, it takes a couple years to return to normal. I think this is going to be a tough period for the next couple of years. I expect it'll take a good deal of time, but we already know that 1 in 5 people will have a mental health diagnosis in their lifetime. We already were pretty overwhelmed. So the more kind of intervention models that we can use in primary care, the better. But I see it's going to be a 1 to 3 year period before we get back to just being overwhelmed rather than where we are now. But maybe overworked. We're overwhelmed now. In the future, we'll go back to just overworked. I'm not complaining. I love my work.
The one thing that has been very welcome is that people have been much more open to getting mental health care when suggested. That part has become part of the new normal, that because so many people were suffering from mental health problems, and you have people on social media and popular people reporting their problems, and there's been so much death and grief. It's been like, before it would be, if I suggested it, sometimes people would be like, I would never do that. And those people are now being like, you know what? Sure, I'll do that. Yeah, give me the number. Or like, yeah, put the referral in, I'll take the call, and that has been wonderful, because the mental health stigma is so much better now.
That's true. I agree.
That was another question, was how do we encourage more focus on this, on behavioral and mental health and just broader society, and what are some things that you've seen that are effective that might work? And I would say that having popular celebrities, athletes come out and talk about their mental health. Naomi Osaka, for example, is one of those things. I have a question from Colin Hennessy. How do we overcome the state-by-state license requirements for those seeking services from providers who may be in different states than their providers?
Yeah, thank you. So we've thought about this, and we would need a national licensure board. It'd be difficult because states don't want to give that up for lots of reasons. But you would need a national. Now, maybe there can be both. You get a state license, and then for a fee, you get a federal license. But that's the only way I think it can be overcome. Can I answer one of the other questions that came up? There's a great question about the squeeze. They're all great questions, but the question about squeezing excess capacity out of the healthcare delivery system. I love that question. Do the markets go too far? So I was involved in managed care more than 20 years ago when it started. It actually started in mental health care because we did a disservice by keeping adolescent patients and those with substance use disorders too long. And so it really started in psychiatry. I'm not happy with my brethren psychiatrists that started this stuff, but there was excess, and we did fix it. I do think we've gone too far. So deductibles, co-pays, they were all intended for several reasons, some to save money, but they were intended to decrease unnecessary care. But I think it's not what's happened. What's happened is it's decreased necessary care.
Yeah, I think I agree. This is a great question, and I agree with what Dr. Yohanna said. I think what is happening, and this actually goes along with another question that's later on about integrative health being a premium practice and becoming more accessible. What I think you're going to see is that people are adding staff. They're adding new types of workers to the healthcare team. Now, they're not adding more doctors. I can tell you that. They're not adding those types of people. They're adding social workers, patient navigators, community health workers. People can actually communicate effectively with patients that are trained to do that. Because we're at a different place in medicine than the 1990s. Thankfully, we have a lot. 1990s were great. Don't get me wrong. We knew a lot about how to take care of people then, but we have had 20 more years of knowing how to take care of people. We have very clear metrics, lots of studies, more trials. And so we have a better sense of what we should be spending our money on. And we're more careful about it because of how much money we spent in the 1980s and 1990s. So I do think the market's got too far, but I also do think that this concept of integrated care is going to become the standard in primary care in the future.
Thank you. A question from Catherine. Does this initiative to expand behavioral health support at UCM extend to student health at UChicago as well?
There is a robust student health counseling service, but we have not moved to add these kinds of interventions that we're doing for burnout for students. Now, granted, none of them were around, so we'll see when they come in the fall. But that didn't stop us from seeing students where they were, in our practice. But no, I regret that we didn't do the same for students.
I would say that the student health providers are aware and get our weekly tips for the behavioral health integration work. And so the types of care, and we've had conversations with student counseling about what we're doing, much more so in this past year, but the initiatives have not started yet. We're in the planning phases.
Great. Well, I think we have time for one more question. This is an anonymous question. How has the traditional mental health provider community reacted to the integration? The models are different. One wants to treat as many as possible, the other to hold on to patients.
So the collaborative care model began in the University of Washington more than 15 years ago, almost 20. We've been training psychiatrists for 20 years, but it's still a slow integration. But many universities will have a collaborative care program, but it is less dispersed into the community at this point. I would like to see every psychiatrist spend a half a day in collaborative care. That would be my goal.
And I would say from the psychology side, therapy side, it's definitely a different model of care. I mean, and so it takes a special type of person to work in the busy practice of a primary care practice, seeing people 30 minutes, getting interrupted, knock on the door. This person's, I need some help, getting interrupted. That's very different than the traditional model. But there are, the health psychology program, we have trainees, interns, externs, postdocs. It's a very popular internship for our psychology interns that do the rotations here. I think that people are seeing the value a lot. And so trainees are very interested.
Wonderful. Well, we are at time, but I just want to say thank you both. Thank you, Dr. Laiteerapong, and thank you, Dr. Yohanna, so much for sharing your work and for doing this very important work for all of us. And I look forward to hearing more about it. And thank you all again for joining us today. We hope that you enjoy all of the programming over the next couple of days at Alumni Weekend at Home. Have a good day.
Thank you.
Bye, thank you.